Good morning, Endo Warriors and Friendo Warriors. It is Kat Stanley here from Endo Health Foundation. I am back from my day 7 walk. I hope you guys are getting out there as well. It is a beautiful sunny day out there today. Thank you to all of you who are taking part in the walk. Thank you to everybody who came to our webinar. Thanks to everybody who's about to watch our webinar online. We wouldn't have a support group or a foundation. We wouldn't have this walk without you, so thank you so much. Our speakers for the webinar were Celia Bolton, Marilla Druitt, Joe Sheedy, and Rochelle Hamilton. They were specifically picked. In some ways, I think I've been looking for professionals like them for probably about 20 years, but I found some great ones. They were picked because they're really passionate about this space. They've done extra pain, reading about pain, learning about pain. They've got extra pain qualifications. They work really well together. I hope you really enjoy what they have to say. Unfortunately, I pressed record maybe about 30 seconds later than I should on Celia's speech, and we missed kind of the introduction. So I wanted to do some of that now. Marilla Druitt did our acknowledgement of country, and she said, "Greetings from Wathaurong country. Australia was comprised of an enormous number of different groups of Indigenous people before European colonisation. The health is worse in many respects to those of non-Indigenous people in Australia. And I think learning about history is important so we can improve social determinants of health." And we certainly agree with that at Endo Health Foundation. We're really aware that all of the research on pelvic pain has been done on white, mainly cis white women, to be honest. And we've got so much more work to do to get data and an understanding of the experience for Indigenous people. We also want to talk about language. We are aware that we want all our events to be inclusive, and that sometimes language and slippages of language can be really hurtful. We've tried to be really inclusive in our webinar today. All of our speakers have tried to use inclusive language. If we have at any point slipped up or made any kind of errors or hurt you in any way, please do let us know, because we are trying to be an organisation that is for everybody. Our first speaker is Celia, and I deleted the introduction, so I will do that now. But thank you to everybody that took part in this webinar, and I hope that you find the information in it really, really helpful. So Celia is the founder and director of Inner Strength Healthcare and the mother of a teenager. She graduated as a physiotherapist in 1991 and has lived in the Geelong area since 1998. She's been working in the area of public health since 1996. Celia has furthered her tertiary studies to increase her knowledge, including women's studies, continence and pelvic floor rehabilitation, and exercise for women. More recently, Celia has become a certified giant mind meditation teacher, studied trauma-informed care and family violence to complement her passion for mind-body holistic care. I really hope you enjoy what Celia and all our other speakers have to say.
Flow, learning a lot, how we can use the energy flow of exercise to improve mental health and releasing nervous energy. And I'm going to talk about mobile meditation and how exercise is a pathway to connection. And then I wanted to really honour an experience I had recently watching this video, and how I thought that you guys are heroes, and I thought this video might be of interest to you. So from the Explain Pain Supercharged, a great book, it's a quote, which is, "Movement and exercise are the best things we can do for all of our body systems: cardiovascular, respiratory, endocrine and immune." And we know immune's really important in the situation of pelvic pain. Now, apologies for this, but I wanted to give you a little bit of a sense of how we have danger detectors. So a pain 101 is our body has all these protection systems. And then one of our protection systems is our feeling system, and that would be touch and taste and smell. But pain is just one system. And I wanted to talk about why it hurts. It hurts because your brain, outside of anyone's awareness, is convinced that your body needs protection. And how do we do this? Our nervous system at the ends is loaded with sensors, which are our danger detectors. So when one of these nerve endings is stimulated, and that could be in your gut because there's a bit of gas, or it could be touch or anything, any sort of touch, it sends a message to the brain, something's happened. But the brain then has to draw on a huge array of info and decide whether what has just happened is a danger, protect, create pain situation, or is it just a rumble in my tummy and I will just change my clothing to be more comfortable? And so the danger detection sensors and the transmission systems are adjustable. So they can have increased sensitivity detection, and then they can have increased transmission. So, for instance, a little bit of gas in one person's tummy would cause a big alert system, or a bit of clothing might set off a big alert reaction. And in the other way, the transmission system might say, oh, there's pain in the gut. And it might say, oh, there's pain from the underpant elastic or something like that. So it's a modifiable system. So there's the technical bit out of the way. Thank you. So motion is lotion. So movement increases our joint lubrication, making everything feel more comfortable. Movement keeps our joint cartilage, the bit at the end of each joint, shiny, smooth, strong and hard. And movement gets blood flowing, which flushes out any stagnant acid waste. Acid waste is just a term for when we sit still too long, we start to get these danger detectors flowing to say, get up and move. And so movement's fantastic. We can also access the natural pain medicine cabinet. So exercise, movement releases a range of analgesics, so painkillers, all over your body. And it also encourages production of anti-inflammatory molecules that calm down sensitized danger detectors and danger transmission nerves. So we have this within us, and walking is a fabulous way to get it. Now, motion is a strength potion. Feeling stronger builds self-esteem and capability. And so any movement we do tells our bones how to best align and to withstand forces, and movement keeps muscle fibers aligned, alive, strong and healthy. Another reason to exercise. Now, in the mood, memory and mental health array, it's not hard to find information here, but what exercise does is it reduces stress and calms the fear brain, which is our amygdala. It triggers new brain cell growth. It makes you think better. It improves memory and reaction time and improves sleep. This is a lovely thing, looking at trauma and how energy flow can be really important. And I'm going to explain this. So energy flow helps us release nervous muscle tension. This is the fear, tension, pain cycle. We all understand this so sort of innately. If we experience pain and we get pain perception, we actually then experience fear, which then sets off our fight, flight, freeze reaction, increases stress, increases anxiety, but also increases our anticipatory fear. And that will cause tension in our neck, our jaw, our belly, and very importantly in pelvic pain, pelvic floor, legs, all around the body can have this increased tension, which then increases pain perception, or the danger perception, and then it brings fear. So it's a cycle that's very easy to fall into. And when we talk about fight flight, I just wanted to make sure that we're on the same page here. Is fight flight is our fear response, and our autonomic nervous system is the mediator of that. So we have the sympathetic, our fight flight, and then we have our parasympathetic, the rest and digest. And this is really fully at play when we have pain. And this is another drawing of understanding how pain, or being aroused in that autonomic nervous system way, we can go into fight flight, we can go into freeze. And in all of those states, we have a physical presence, but we also have an emotional presence. So we might have a feeling of helplessness and being trapped up in the freeze, where our nervous system's got full accelerator muscle and full brakes. And we can have fight flight, and we can have our social engagement system. I have just realised that I am, just excuse me, running out of juice in my computer. I'll just go and get it.
I thought that was mine. I was looking to make sure it was plugged in.
Sorry about that. There we go. So the parasympathetic and sympathetic nervous system really affect our organs. So it's really relevant for if you have pelvic pain. So walking releases muscle tension. It's a great way to deactivate off that fight, flight or freeze. And it's getting movement and flow of energy is a fantastic for people that are feeling really activated and aroused. The second last thing is that you can do a mobile meditation. So in fight, flight or freeze, if you're asked to do mindfulness or meditation, it actually feels impossible because the fight, flight physiology of racing heart, muscle tension, altered thinking where you're thinking really fast, and often the thing we want to do is we want to avoid sitting with our eyes closed and letting our guard down. So the beauty of walking is you can do walking mindfulness, and it's a huge leap forward for the fight, flight and the pain. So you can either, when you do it, and I recommend you watch my pacing video that is on the page, you can either focus inward on your breath, or you can be outward focusing, and it's just so natural to look at sights, sounds, smells, and it's fantastic when you're out and just looking at rainbows and rain and all the things that we do when we walk. The other thing that's fantastic about walking, it's a pathway to connection. And a social interaction is a basic human need. And when we go walking, it opens up all little low commitment social opportunities, especially if you've got a dog. And the other thing about that is fitness is a gateway to tolerate more activities, which increase your your ability to have more connection. I just wanted to finish about the idea of you going on a journey with this walk that you're committing to. And so each time you go out walking, you're actually on a journey. And this beautiful video that I'd recommend called Finding Joe, where an anthropologist has looked at all the stories around the world and talked about the hero's journey being pretty much the central tenet to most stories. And I just want to acknowledge and honour the pain, frustration and confusion of the journey that you have unwittingly come across. And what this video talks about is how the hero encounters huge obstacles and is forced to face fear and go beyond it and grow a bigger sense of self, and how there's actually some positives that can come there to gain power of an understanding of yourself, but just power in your own life. So every small step helps. Thank you. So sorry, everyone.
Thanks, Celia. Does anyone have any questions that they wanted to ask now?
Sorry, it took a bit of time to get on, Celia. But I'm on.
Hi, Jenny. Good to see you.
I got on eventually.
Great.
Should I mute myself again?
Celia, I've got a question for you. Can you talk to us about the relationship between pelvic muscles and pelvic muscle pain and endo and pelvic pain and period pain?
Yes, I can. Yep. So back to that fear tension cycle, Marilla. It's very natural when you're experiencing pain, and it could be an event long ago, or it could be a current event, that we brace against it And so when we experience pain, we carry this tension in our body, and it's that itself causes the fear and also causes the pain. And it just ends up in this cycle. But the pelvic floor, there's research that says that our pelvic floor is a very reactive muscle to emotional events. And they did some research where they showed videos, emotional videos, and they noted that when something violent happens or something exciting happens, there was a lot of tension there. So the relationship between pelvic pain and pelvic tension is just completely integral.
And Celia, also just following on from that, maybe good to mention the sorts of, you've talked about it a bit, but just the sorts of things that can help address that.
Oh, yes. Well, I mean, there's so many things.
Yeah, that's a 3-day course in itself.
Yeah, it is.
In a snapshot.
In a snapshot, it is about getting moving, practicing getting aware of that part of your body, and being able to, by then noticing it, then you can know the difference between contracting and relaxation. Other things can be, move, touch, massage, heat, specific exercises that might address through the pelvis. Often people, when I see people with pelvic pain, you get someone to stand on one leg, and there's a whole array of asymmetry that can happen, and it can be just almost normal, but it seems to get exaggerated. You know how we all carry our bag on one shoulder? We can have just that asymmetry or imbalance all through our body, and those things seem to get amplified. And so by doing specific exercise, which is all about movement, is use the muscle, relax it, use the muscle, relax it, use the opposite muscle to help the one that's tense relax. So there's lots of physio techniques, but it all the best things you can do is actually the things that you do for yourself. So there's what's considered an active strategy and a passive strategy. The things like a hot pack is a passive strategy. An active strategy is where you do something that requires movement, and you're not asking someone to do that for yourself. The research says that the active stuff is so much better.
And I think as well, it's really important to highlight the ways that we manage parts of our body when they cause us problems or pain. And we often unconsciously get used to kind of pushing that experience out of our awareness, or kind of blocking our awareness of that part of our body. And you don't just see that with pelvic pain, you see that with any part of the body that chronically causes problems or pain. And so it's really important to even just mindfully begin to reestablish a connection if that feels okay and feels safe, but almost kind of, exploratory, just sort of exploring and starting to make a connection again with that part of your body in a way that feels safe.
Yeah. And as you know, Jo, I've noticed that actually it works much better, especially when on first meeting somebody, is that we acknowledge the stress that can be with an assessment, and actually go, okay, how aroused or stressed are you at the moment? Let's find ways that you know that your nervous system can change, and using strategies of connection that have nothing to do with the pelvic floor or the tummy or the back. It's actually just knowing how to alter how stressed you are in that moment, which is actually quite empowering. And I use those strategies myself, and they are slowly connecting back into your body.
Yeah, I think it's important to kind of just notice that that's a common way that we all cope with discomfort or unpleasant sensations in the body, is that we often distance ourselves from them psychologically, and then we find that it's hard to get back to it, and that can cause problems in itself.
Thanks, Jo. That's terrific.
We've had a question come through as well, Celia. Is there a certain amount of time we should walk for to make sure we activate our parasympathetic nervous system, e.g. 10 minutes, 20 minutes?
No, I'm not going to give you a number. because you could stand outside. I mean, I was just doing that before. I saw 2 little fairy wrens and a little baby, and that's my parasympathetic nervous system just right there. So there's not a dosage there. I think if you could, if you want to improve, if you can do 300 meters and you do that regularly, you're going to have an improvement. And so, and what we talk about in that pacing video is that you get to a point where that 300 meters is comfortable, it feels safe, that's activating your parasympathetic nervous system. Every step helps. I love it.
Yeah, that's exactly right. You might just go to the letterbox, but every step, even just being outside for me makes a big difference.
Yep.
If you've got any other questions that you think of, please just put them in the chat and we can come back to Celia. Our next speaker is Dr. Marilla Druitt. Marilla is an obstetrician gynecologist who trained at the Mercy Hospital in Melbourne, rurally in Warrnambool and Wangaratta, and overseas in Ireland and Vietnam before moving to Geelong in 2011. She has completed a fellowship in advanced, laparoscopy? I think I've got that right, at Monash Medical Centre, and has a special interest in endometriosis and pelvic pain and minimally invasive surgery, including hysteroscopic management of fibroids and total laparoscopic hysterectomy. Marilla is the gynecologist at the amazing multidisciplinary persistent pelvic pain clinic at University Hospital Geelong and teaches medical students and does research with Deakin. She's currently conducting research on the HAPPY study, which is a study looking at cognitive behavioural therapy, yoga and education for pelvic pain. As with all research studies, they're looking for participants, and if you'd like to take part, I'll include the email that you can contact in the chat for you all. Marilla.
Thanks, Kat. Hello, everybody. Thanks for having me. Thanks to Endo Help for asking. Thank you to all the people on the webinar. Thank you to all my patients from whom I've learnt lots and lots and lots. And one of the earliest, most helpful patients was one of the ones who recommended that I read Explain Pain, which was the book written by Lorimer Moseley and David Butler that Celia was talking about before. So that was a win. To my colleagues, including Antonina and Jill, who are on this webinar. So Antonina is one of the psychologists in the HAPPY study, one of the chief investigators, and Jill's our yoga teacher. To my fabulous colleagues. And what I am aiming to talk about today is the concept of a thing called a biomedical approach to a medical problem versus a biopsychosocial spiritual approach to a medical problem. So this is where I'm talking from. These are 2 very helpful resources that I want everyone to have a look at if they haven't already seen them. So I was involved in writing our endometriosis guidelines for Australia, which was a very interesting thing to be part of. And so if on average it takes a doctor about 17 years to change their clinical practice according to new evidence, that's a bit slow. Actually, that's very slow. So I want everybody else to be over these guidelines so that then you can take them to your doctor and say, why aren't we doing this? RATE is a really handy survey or tool that RANZCOG and the National Action Plan funded. And what it does is you put in all your symptoms, like, you know, you've got period pain, or you've got pain when you do a poo, or sexual pain or whatever, and it puts it into doctor speak. And so then you can take the report, or it emails you a report, and you can use that to help advocate for yourself and explain your symptoms in language that maybe doctors might pay a bit more attention to. So I was just going to do a bit of a recap of anatomy. Can you see my mouse on my screen?
Yep.
Yep. Okay. So this is a chopped in half view of uterus and endometrial lining, ovaries, tubes, cervix, vagina. And then this is a chopped in half view this way. So bladder at the front, uterus in the middle, bowel at the back, and all of these pelvic floor muscles holding everything in, stopping everything falling out. Just so we know what we're talking about. So endo, as I'm sure everybody knows, is where tissue which is like the lining of the uterus is somewhere else, which is usually in the pelvis, but it's been found in all sorts of places like lungs and noses and in, you know, people who are born XY and men and women. And 1 in 9 Australian women between 18 and 44 have had this diagnosed, and this is on a big study that Geeta Mishra and co did up in Queensland. Endo is associated with pain, subfertility, other pain problems, but sometimes nothing. So sometimes when we go in and we're tying someone's tubes, they've got endo everywhere, but never had any pain problems, never had any fertility problems. So it's an interesting disease. The pain that it can be associated with can be pelvic pain, period pain, sexual pain, cyclic or everyday pain to do with bowels and gut or bladders. And so this table is from our new clinical guidelines. So you can find all of that on there. We diagnose it mostly with ultrasound in Australia because that's usually the imaging that is funded. And so that can be a scan through your tummy, a vaginal scan, but the expertise is very varied. And so a general ultrasound will also be able to look at livers and spleens and kidneys and say things like, there is a uterus, there might be adenomyosis, which often goes with endo, there might be ovarian cysts. And then at the other end of the spectrum, they might be able to say there's endo on a ligament holding the uterus to the back wall, there's bowel involved, the bowel stuck to the left ovary, and it gives us a map of the pelvis, which can be really handy if someone needs an operation. MRI is also really good, but it's not funded in Australia for women's pelvic pain, so that is a problem. We're trying to fix it. CT is very good in the literature published, but nobody in Australia particularly uses that, so we don't have many people who can report that. And of course, our diagnosis traditionally has been with laparoscopic surgery and looking in people's bellies. So this is what a pelvis looks like when there is no endometriosis. So this is the view down from the belly button down to someone's toes. So this is uterus in the middle. These white things are ovaries, big uterus ligaments holding the uterus to the back wall, little frilly, floppy things, which are the fallopian tubes, and this is the rectum at the back. And so endo can have all sorts of appearances. So this little blob of red stuff on underneath the uterus, that can be endo. This sort of white scarring stuff over here, that could be endo. And then all of this over here on the right side is ovary and bowel stuck to the back of the uterus. Staging, which many of you might have read about, is very useful for us to work out how long an operation might take, not how many symptoms somebody should have or how many fertility problems somebody might have. And it helps us work out who should be doing an operation. So do we need help from a bowel surgeon or not? Endo is associated with bladder problems, which is why physiotherapy help can be so important, such as urgency when you feel like you need to go all the time and you are worried you're not going to make it, or trouble emptying because the pelvic floor is really tight and the resting tension is high, or pain trying to do a wee. Similarly with bowels, so alternating diarrhea, constipation, IBS, pain doing a poo, pain before doing a poo, and bloating. Bloating is really common. Endo is associated with depression and anxiety, and we think that there's a genetic link there too, and that's some of Grant Montgomery's work out of Queensland. And other pains. So if you have one pain, you're more likely to have other pains. So you're more likely to have sexual pain, migraines and headaches, PMS, rheumatoid arthritis, Crohn's disease, lots of other pain problems. Just a quick word on subfertility before I talk a bit more about pain. So if someone has trouble getting pregnant, and it takes maybe, 85% of people should be able to get pregnant within 12 months. Medicines and surgery are what we argue about in terms of treating subfertility associated with endo. So the medicines are IVF and other assisted reproduction techniques, like helping people ovulate if they're not ovulating, or using IUI, which is putting sperm into the uterus, or surgery. And so there's much discussion about surgery and whether or not that's useful for endometriosis fertility problems. And so when we're at conferences, everybody argues about IVF versus surgery, and they've got pros and cons. So the IASP took a long time to come up with this definition, and pain is something that's unpleasant, it's something that's sensory, and it's also emotional, which is why psychology is so important. And so it's an experience that is associated with, or it feels like it's associated with, actual or potential tissue damage. So for example, if you are missing your arm, you can still have phantom limb pain, and we know that the arm's not there, but sure feels like it is. So in our new national guidelines, treatment for pain associated with endo, we basically have one class of agents, and that is hormones. Medicines seem to be just as good as surgery for pain, and possibly medicines might be a bit better. More endo is not associated with more symptoms. So some people have a little bit of endo and lots of pain, and vice versa. And it's important that we treat the woman, or we treat the person, not just the endo. So endo is a risk factor for pain in a similar way to smoking is a risk factor for pain, or past trauma is a risk factor for pain. It's one component. I see lots of patients who have tried lots and lots of over-the-counter pain medicines, and really, when we look into it, there's not very much evidence at all that things like ibuprofen or Ponstan or aspirin make much difference at all. All hormone treatments seem to be equivalent when they get studied, and so then we pick and choose on which one someone likes, that doesn't give them any side effects, that makes their lives better, not worse, because we're not about trying to swap one set of horrible symptoms for another bunch of horrible symptoms. But sadly, unlike things like asthma or diabetes, we've really only got one class of agents, and that is hormones. Hence, you need to do more research. So these are all the hormones that we have. So we've got Depo-Provera, which is an injection every 3 months for ovarian suppression and no periods. We have the traditional pill. We've got Mirenas, which are the best invention of the last 20 years, but not for everybody. We have ways of making people temporarily menopausal with a nose spray or Zoladex implants. We've got progestins. We've got 20 different types of progestins, so chances are there might be one that doesn't make people feel worse and makes them feel better. And then we also have to factor in things like, do they need contraception as well? Some trans considerations. Again, we should tailor the treatment to the person. So often when people with a uterus start their testosterone therapy, they can have bleeding for 6 to 12 months, and often that will then go away. Hooray. But if it doesn't, again, there's a whole bunch of other things that we can try, in particular oral progestins such as cyproterone or a Mirena, which then only the person knows that they've got in them. And some people choose a hysterectomy if they don't want their uterus. This is our current position statement on how to manage hormonal problems in adults who are on testosterone therapy. In terms of surgery for endo and pain, I know that there's heaps out there about should I go to an excisional specialist or someone who does ablation, on pros and cons of these techniques of treating endo. But just to take it back a step, this review, which is by a group called the Cochrane Group, and they're a massive big international collaboration on how do we work out what is the truth in medicine. They put a whole bunch of studies together, reanalyze the data and work out answers to questions. This one came out in 2019, or no, sorry, last year, 12 months ago, October 2020. And they found that even though laparoscopy is fantastic for diagnosing endometriosis, because we can see it and we can pick it out and send it off to pathology and find out what it is really is pretty uncertain whether or not lap surgery reduces overall pain with minimal to severe endo, so stage 1 to 4. This has not had a lot of press for many reasons, I'm sure you can imagine. And so certainly laparoscopy surgery can work for some people, and pain and endo, but we're bad at predicting who it might work for and who it won't, hence the importance of doing all these other things. So usually I draw people a picture like this. So this is all of the things that are giving them grief. And so if they have period pain, well, let's work out how to get rid of the period pain. If they're getting PMS or ovulation pain, how do we get rid of, how do we generate ovarian suppression? How do we sort out bladder problems, pelvic floor stuff? What are we going to do about the gut symptoms and treat IBS, exclude celiac disease, make sure that pelvic floor is really good? And then if someone has endo, the challenge always is to work out how much of the story is endo. Is it 1% of the problem? Is it 50% of the problem? Tricky to know. no tests. Muscles always should be in there because we absolutely need to address them. And often I tell people that I just feel like a physiotherapy triage service when I see people. And then over here, you can't have pain unless you've got a brain. No great surprises. So just a quick word on IBS treatment. I'm sure most of you are all over this, but if you are not, the low FODMAP diet can be very helpful. And so frequently people with endo and pelvic pain will have lots of crossover other pain syndromes. And so IBS treatment, I like it because you have to eat food anyway. And so if you haven't worked out what the foods that upset you are, well then that's, you know, a sensible thing to do. But also a thing called gut-directed hypnotherapy is a bit of a winner. So we've got excellent evidence that that makes a difference. And it's not hormonal, it's not a medicine, and it seems to be a durable treatment. So at the moment, the groups that I send my patients to might offer between 6 and 12 hours of treatment. So an hour a week for 12 weeks or 6 weeks. And gut hypnotherapy seems to be associated with lower rates of pain, headaches, fatigue, and less likely to need to see a doctor in the following 12 months. My other favourite drug is amitriptyline, and that is good for lots and lots of reasons. So there's a good link on the Pelvic Pain Foundation about amitriptyline. Right, as Celia said, you can't have pain if you don't have a brain. So the picture that I usually draw people is all about signal coming in from the periphery. So uterus down here contracting, or bladder filling up, or bowel pushing your food through, or tiger chewing your leg off. So for each signal that comes into your brain saying that there's something happening, on average, there's about 100 nerves running down in the opposite direction, which are there to ignore things or modulate that signal. And then it relays through your brainstem, and your brain has to work out, given everything that's ever happened to you, plus where are you in your cycle, plus past trauma, plus your genetics, possibly the bugs in your gut. Are you having a good hair day or not? Should you make pain to get yourself out of trouble? Or who cares that your bladder's filling up? You're busy watching a movie, it's not about to pop, ignore, don't make a symptom. So in medicine, we really do love a bit of what can we chop out in the periphery, but as long as we've made sure someone doesn't have cancer, we should also help their brain ignore things better. And so the way that we can do this, one of them, and I'm sorry, this is a bit messy, one of the ways that we can help people ignore stuff is with exercise. So there was a very cool study that I was reading the other day about runners who love exercising, obviously, and trying to work out what the mechanism for their runner's high was at the end of their run. So they tried blocking all of the receptors that morphine and codeine, all those sort of medicines act on. That didn't make any difference to their runner's high. But when they blocked the marijuana receptors, or the endocannabinoid receptors in their brains, they lost their high. So maybe exercise is all about a natural way of getting some marijuana into people. And that's what makes them feel good. We have medicines to do this. Sunshine seems to make a difference. Sleep is really important. CBT works very well, which Joe will talk about soon. So does meditation. And if people really struggle with meditation, it's probably better for them than the ones who find it really easy. So sleep, interestingly, in medicine, we're not really trained to ask lots of sleep questions, but it turns out that if someone has a sleep problem now and no pain, they're more likely to have a pain problem in the future. So it's really hard to get people's pelvic pain fixed or endometriosis associated pain fixed if we don't fix their sleep. And so as well as all of the sleep hygiene measures like getting enough, don't be on your phone until you go to sleep, don't drink a cup of coffee at 9 p.m, don't have a huge variation in your wake up time. We have some nice trials about melatonin that seem to work in women with endo and pain, and CBT for sleep also helps. So the last two things I'm going to talk about are health literacy and pain education, and then I'll hand over to Rochelle and Joe. So the reason why we walk, I think, partly is to raise awareness and teach the community. So health literacy, as this doctor said, he was the Surgeon General of the States for a while, it's the ultimate global currency of health and wellbeing. And without health literacy, medicine fails, public health fails, and people pay the cost for these failures with their lives. So if someone or a population has low health literacy, they don't engage with health services particularly, they don't do as much preventative screening, they have higher readmissions to hospitals after operations, they don't understand their medicines as well, and they can't manage their health issues as well. So perhaps pain education and awareness raising months like this one result in higher health literacy. And so then maybe that's partly the mechanism for reducing pain. People who learn about pain, and there was again a famous study in Adelaide about back pain, and 2 groups of this is how you pick things up, get your ergonomics sorted, versus pain education, teach people about the neuroscience. The neuroscience group did better, so that the more people learn about pain, the less pain they might have. So why walk? Again, if you need some good hard science, again, we've got a Cochrane review on chronic pain in adults, and there is fabulous research evidence to say that it makes a difference to decreasing pain. We also have one from Mike Armour's group in Sydney, and he is a complementary medicine researcher who does lots of research in endometriosis, and period pain or dysmenorrhea seems to be treatable also with exercise. So we don't have one for endometriosis associated pain, but I'm sure that will be coming. There was one study, but it got withdrawn because it was a bit dodgy. So it became unpublished. Then finally, as Kat said, Deakin is running a trial on a mind-body intervention for pain associated with endometriosis. And so you have to be over 18, you have to have had a previous diagnosis of endometriosis at laparoscopy, which we all argued about, but that was what the government funding was contingent on, and persistent pain. And so it's usual care versus 8 weeks of CBT with the psychologist, and that's in a group online, versus 8 weeks of yoga with Jill online. And then the usual care group can choose one of the other 2 after they've completed their part of the study. And so if you're interested, email that email at the bottom. Our recruitment's going really well. And then if you still haven't read enough, then this is my pelvic pain baby from 2019. So this is our ONG magazine that my college publishes, and I'm on the committee for. And so we got to gather up lots of people whose ideas we knew aligned about muscles and psychology and surgery and medicines and all sorts of things. So again, that's online. And that's it from me. Happy walking. Thanks, Kat.
Thanks, Marilla. Does anyone have any questions? Oh, I've got a question that says, for the study, does it matter if you've had a hysterectomy and therefore don't have a uterus?
No, if you've had endo in the past, you're eligible for the study.
And does a diagnosis by ultrasound mean we aren't eligible to join the study?
Yes, which is really dumb, but that was the only way that we could fund it. So we did start the study with an attempt to make it just a pelvic pain study, but because the government is, you know, the government's finally worked out what endometriosis is. Hooray, that's very good. But now they just seem to think that that is the only thing that matters, which is obviously a bit silly. But that is what we've got at the moment.
Someone has said, can we please have the websites again for further research?
Oh, sure. You can. I'm happy if you want to share the slides after.
Yep. Okay. I'll send them out.
So Pelvic Pain Foundation of Australia, fabulous resource. ONG magazine. If you just Google ONG magazine Ranscog, and then the PPFA and Endometriosis Australia have also got the link to the HAPPY study. Oh, thank you. Oh, yeah, I'll put them in the chat. Good idea.
Does anybody have any other questions? Yes, we can. You can access this recording later, and I'm so sorry that I said we were going to record it and then forgot to do it for about 5 minutes, so we've missed the first 5 minutes.
We'll get better. Next year's will be better, Kat.
That's right. Does anybody have any questions? We had a question come through, Marilla, which was, can an overactive pelvic floor and endo be related? Oh, yes. So Susan Evans, so she's the guru who started the Pelvic Pain Foundation with Tricia Newman, who was a physiotherapist that she was working with. She would say that there is a thing called a somatic visceral reflex. So visceral somatic reflex. So something in your tummy, so IBS for 20 years or one really good UTI or endometriosis or something happening in your belly switches on all of the muscles around. So it's really uncommon to have
pain with endometriosis and not have an overactive pelvic floor that is responding to the things that are happening in your tummy. So the idea is you've got to switch off the primary reason and then rehab those muscles. So you need to do both. Yeah, but it doesn't help if you have a hysterectomy and fabulous surgery if you then don't rehab those muscles, because they will stay tight and part of the pain problem.
I've got a question that said, how bad does the pain need to be to take part in the study?
Antonina, do you want to answer that?
Sorry, I need to unmute myself. Hi, everyone. Well, the pain can be at any level, really. That's not really a problem. We're very inclusive in this study.
Yeah. And then Steph's asked, if you experience debilitating symptoms from hormonal treatment that are just as bad as your endo symptoms, what other options are there? Yep, that's a good question. So we should use the lowest dose that does the trick. And so at the back of the Endometriosis New Zealand guidelines, there's a great list of progestogens. So often people have not tried all of them, and they all have slightly different receptor actions. They act on progesterone receptors, estrogen receptors, androgen receptors, glucocorticoid receptors, mineralocorticoid receptors. So chances are that most people probably haven't tried all of them. But of course, some people, they're trying to get pregnant, so they can't be on hormones anyway. I find often that it's handy to target things as a PMS type approach. So if someone has mid-cycle pain and then they have awful PMS symptoms, sometimes they then get migraine in the 3 days before the period happens when estrogen falls, that time can be good to target with something like an SSRI. So the current anti-anxiety, antidepressant medicines, you can plug them in for weeks 3 and 4 and then stop them, on for 2 weeks, off for 2 weeks. And so we've got 7 trials of different medicines that can be really useful to use for those symptoms. And we think that they mop up the high estrogen and progesterone in the second half of the cycle quite well for some people. So they're good evidence-based treatments from a PMS point of view. And then fixing sleep. Amitriptyline is a great drug. And so on the PPFA website, they've got a really good list of symptoms. And often I look at it with my patients and they say, oh, yes, I've got bloating. Oh, yes, I've got vulval pain. Oh, yes, I've got IBS and overactive bladder. And, they meet lots of they have lots of the symptoms that this medicine can be really useful for. CBT. So Joe's going to talk about this soon. CBT has fantastic evidence for pain. And so if hormones are only one thing of 50,000 things you can do for pain, just because our biomedical approach is we always offer hormones first, that doesn't mean that the other 99 things shouldn't be considered. It's just that it's tricky in our medical system to do things holistically. Yeah. So if we know that things, particularly pain, is really hard to fix unless you go broad, unless you cast a really wide net. So of course, plenty of people get better and they keep on ovulating, they keep on having periods, but they don't care about it anymore. They don't have pain anymore. So because all of those other things are covered, particularly brain stuff.
I've got a question that says, what are your thoughts on CBD oil for endo pain management? Are doctors hesitant to prescribe it due to stigma?
No, I think doctors are hesitant to prescribe it because we've got no evidence it works for pain yet. So all of the evidence says doesn't make any difference to pain. Probably makes it, there's a fair bit of evidence to say that it can work for anxiety though. So then, because those two things are so overlapping, people who have pain are way more likely to have depression and anxiety. So then for a quality of life approach, if you get rid of lots of the anxiety, well, then maybe that's why your quality of life goes up. As Celia was saying before, though, there is this idea of passive treatments versus active treatments. And so because CBD oil is a passive treatment, it's something that somebody else gives you, I want someone to max out all of their other things first before they start trying things that we don't have very good evidence for, that are expensive, that somebody else gives you that you don't do for yourself. So, none of the pain physicians that I work with prescribe it because I don't think it's good enough. And we would love it if it was good enough. We'd be onto it. I'd have shares in the company. All right. Is it time for Joe or Shell?
Yes, thank you, Marilla. Our next speaker is Jo Sheedy. Jo has joined Inner Strength in March 2017. She holds dual qualifications in both psychology and physiotherapy. She initially qualified in physiotherapy in 1990 and subsequently worked as a physiotherapist for 20 years before pursuing a passionate interest in mind-body health and retraining as a psychologist. She studied an honours degree in psychology before going on to study a Masters of Psychology and a PhD through Monash University. Jo's PhD thesis explored psychological risk and particularly resilience factors associated with coping with chronic pain. Jo has experience in treating a range of psychological conditions. She uses a variety of therapies that include cognitive behavioural therapy, acceptance and schema-based approaches. Jo provides individualised, respectful and evidence-based psychology treatments. Jo.
Thanks, Kat. Just hopefully nail this screen share. Here we go. Share. And slideshow. Now I'm just really mindful of the time, so I'm going to probably race through my presentation. I can't quite get to my slide share under the Zoom thing. Oh, here we go. Can you see it like that or not?
Yeah, we can see your slide. We can see
Yeah,
the small ones down the side, which doesn't matter.
It's all right. It's all right. I'm onto it. Okay. How's that? Can you see the slides now?
Yep.
Great. Okay, so yeah, I'm mindful of the time, Kat. What do you want to do? Because my presentation is probably longer than 10 minutes. And do you want me to kind of just race through it?
Yeah, do your best.
Yeah, okay. I'm going to talk quickly then. What I'm going to talk about is probably mainly pain science because I'm passionate about it. I really want people to understand it. And it's a really nice segue leading on from what Marilla talked about. The strategies part is the second part of my talk. It really only just skims the surface of what a pain psychologist can help with. Probably good not to get me started on my passion for psychology because I just love it so much. I think it's got so much to offer everybody. But yeah, so I'll just talk, I'll get through what I can. And I just guess I'd like everyone to take out of what I'm going to present that there is a lot of good help available through psychology for pain, for endo pain. I treat a lot of endo pain at Inner Strength, and yeah, there's a lot of scope to help people cope and live with this condition. The other thing I just wanted to say is I feel like in this event that we're bringing endo and power together, visibility, I love that. It's been such a condition that's been under-recognised and under-treated, and I think, Kat, you're to be commended for all your work in this area. Okay, so now I just can't get my slides to go down. I'll just have to scan like this. Can you see them like that? Can you see that, everyone?
Yeah, we can.
Yeah. All right. So I'm just going to kind of go quite quickly. So I guess what we do know about pelvic pain, endo pain, is that it's often really distressing and people can feel really alone with it. We also know that the diagnosis and treatment of it can sometimes be prolonged. It can be confusing. And for some people, I know definitely traumatic. And also wanted to acknowledge that mainstream medicine has been slow to acknowledge and understand pelvic pain and to offer evidence-based treatments. Like Marilla's a real hero in this space, but not everyone has her skill set and understanding. So for everyone else that hasn't seen Marilla, I think we just want to recognise that sometimes it is a tough journey, and it's lovely to flip it around, like you said, Celia, and see it as a hero's journey, but it can be tough, and I just want to really acknowledge that. The other thing I just wanted to highlight, I'm not going to spend any time on it, but obviously psychology and what I'm going to talk about is only one piece of the pie. I think Marilla's covered that really well. What I'm going to talk about is the differences between chronic pain and acute pain and the cycle of suffering. And then if we get time, I can rip through some little strategies. I think the main thing that I'll focus on in what I'm going to present is really following on from what Marilla was talking about, which is how can we explain the idea that the degree of endo, the stage of endo, the clinical presentation, what we see on a scan doesn't always match or often doesn't match the symptom severity. And so that's what I'm hopefully going to unpack a little bit and help people understand why that is so, why that can be so. So Celia's talked to this a bit, but I guess it's just good to look at pain from an evolutionary perspective, and that is just to understand that the primary role of pain is to protect our body. That's how we got it. That's what our pain systems are for. They've acted as warning signals to tell us there's a problem in the tissues. And in the setting of acute pain, that works really well. It tells us when our finger's in the gas heater or the gas, burner on the gas stove. We've rolled our ankle, but it does not help us as much in the setting of chronic pain. In chronic pain conditions, what we see is a range of adaptations that occur in the nervous system. And so what it actually means is that over time, any chronic pain condition, endo or any other chronic pain condition, a lot of the pain, as strange as it is to say, is actually maintained, what we say, centrally or in the brain. So I'll just try and unpack that a little bit more. So acute pain is really your body's response to an acute tissue damage. I think we've talked about that. But as the tissues heal, that pain gets better, things go away, it responds to simple, treatments and of your uncle. In the setting of chronic pain, the pain continues and it doesn't always match with the degree, of what's going on in the tissues or even the degree of healing that we might expect or the severity that we might see on a scan. So I guess just highlighting those differences between acute and chronic pain. So why is that? Why is the correlation low between, what we see on scans and what the symptoms feel like? It's all to do with the complexity of the brain and the pain signal and how pain is processed in the brain. So in the olden days, back in, 1950s and 60s, when people started studying neurophysiology of pain, there was a kind of thinking that there was maybe a single pain pathway, like a pain message that kind of came up through a pain nerve and up into the spinal cord and was processed by a single pain processing center in the brain. And then subsequent years of research have debunked that completely. And how we understand pain works now is that it's really, really complex. There are many, many parts of the brain that are involved in pain processing, including parts that you may not expect, like the part that makes meaning, the part that processes memory. There's just a whole lot of different parts of the brain. And what we see on MRI studies is that over time, the longer people have a pain condition, the more of the brain that often gets involved in processing that pain. And so that's a good question. Why does that happen? So I always explain for people that I have in my room the idea that our nervous system is one connected organ. So I often say if we could cut the top off the top of our head and we could extract your brain, what you would have is your brain dangling with the spinal cord and all of the nerves that are coming off it. And so in that sense, every single part of your nervous system is connected to the rest. So what happens in your big toe and your left foot is connected intimately to what's going on in your brain. And the other part of the nervous system that is a key property is what we call neuroplasticity. So neuroplasticity is the capacity of the nervous system to change and adapt and grow over time. It's a key survival aspect for our species, for all species. I'm sure every species that has a brain and a spinal cord, there's neuroplasticity going on. And so basically what that means is the brain rewires itself just according to what we do the most of. And that kind of makes sense from an evolutionary perspective, because if you think about when we learn a new skill, driving a car, playing a musical instrument, we don't want to do that with the same degree of difficulty that we do it the first time we do it. We want to get more efficient, otherwise we'd just be exhausted every day. We get up and it'd be like climbing a mountain. So if you think about some of those things that most of us have learnt to do, everyone's done, mastered a skill. And the fact that you get better at that speaks to neuroplasticity. So what's actually going on behind that change or that efficiency is that your brain is recruiting a whole lot of new neural networks. If we go back up to this slide, you actually get neurogenesis, you get new nerve cells or neurons developing. Those neurons connect to other neurons and through synapses or connections. Those connected neurons develop into neural networks through strengthened synapses. And as well as that, there's a process of pruning that's going on all the time in our nervous system, so that networks that we're not using a lot of, we prune away and they become less efficient and we're less able to call them up. So this is a fascinating and amazingly fantastic capacity about our nervous system. it's nearly always good. But in the case of chronic pain, it is not so great. Because when we get good at driving a car, or we get really good at playing a musical instrument, so our nervous system also gets good at doing pain, unfortunately. And we recruit in more neural networks, and we recruit in faster connections, and the thresholds to send the messages to the brain, they start to be sent at lower thresholds. So things that beforehand may have caused, I think in that example of your bladder being full, if you've got a chronically sensitized pelvic area, what you might have perceived that as was a pressure sensation. But if you've got chronic pain, what your brain will perceive that to be is a pain sensation. And that's just the reality of how it works. So over time, what it kind of means is that the trustability of that pain signal and the intensity of it becomes much less reliable over time. We can't really trust that the amount of pain that we're feeling is indicating the degree of damage or injury in the tissues. And that's how come the correlation between pain and scans and, stages of endo is not very high. It's because it's way more complicated than that. And obviously I'm not going to have time to unpack any of the really complicated things that I just turn me on so much in the brain, but obviously people's memories, what they've been exposed to before, their genetics, all of this comes into how their brain is able to process pain. Importantly, and I'm just really watching the time, but I'm super, super aware that I don't want anyone to walk out of this talk thinking that what I'm saying is the pain is all in your head. Well, it kind of is. It's in your brain, but it's definitely not imaginary. And also, most importantly, the last thing I want anyone to think is that because all these changes have happened in the nervous system, that you're stuck with it, that there's nothing you can do about it. Because one of the beautiful properties of neuroplasticity is it will go one direction, but we can also reverse it. We can also work in the wisest way with our mind-body system to create some positive change. And that's what the rest of my slides are dedicated to. So actually, there's actually a ton of hope, and that's what my clinical work focuses on with people all day, every day, and I love it. So I'm not going to have time to unpack too much more of this. I guess the most important things is this idea of trying to create safety for self. And I think what I hear a lot from my patients, and again, I'm grateful in the same way Marilla expressed that they've taught me so much, but there's such a negative self-concept that can come with having endo, that you feel defective as a woman, as a partner, as a lover. And I think it can lead us to all sorts of ways of interacting with people that are probably not optimal, or it can do that anyway. So, and it can create a lot of stress in our lives. And I guess what I wanted to really talk about was the idea that we want to harness our power to begin to create safety. Safety is a great antidote for pain for all the reasons that the other speakers have already mentioned, around a fight-flight response, cortisol levels, stress in the brain, that sort of thing. So there's all sorts of ways we can build safety. I always start outside in with anyone that I'm working with. So if your environment is unsafe, it's crazy to think about trying to create safety within yourself if you're in a difficult relationship, or you've got a terrible job or a stressful job. So really trying to think about your environment and doing as much work, wisely as possible to create safety with other people. Setting boundaries, saying no. I've got some slides here, which I'm happy to share the slides because I'm not going to have time to unpack it, but I really like these rights. I think when we've got a chronic health issue, it's, like I said, it's easy to kind of subjugate your needs and feel a bit defective. I think it's really important to recognise that in those settings, your rights are as important as anybody else's, possibly more. And just recognising that you have rights just like every other person, and you have the right to, negotiate for change, to say no, not to take on other people's problems. There's a whole lot there that you'll see if I share the slides. I'm going to try and finish in 2 minutes. This is another whole topic just in itself, but pelvic pain, what Celia and I talked about this a lot, what we kind of think, and Marilla, I'm sure you'll agree with the idea that when your pain is in your pelvis, and it's the same when people have pain in their chest or their lungs, it's so close to your vital organs, that it's your natural brain response to kind of keep paying attention to that because of its proximity to the things that keep you alive. And I think it is different to ankle pain or wrist pain in that way. So we just have to be mindful that your brain is going to keep paying attention to your pelvic pain, and you can work with that. You can really try some strategies to notice that that's what's happening and to gently and kindly take your attention somewhere else. So there's all sorts of, ways within mindfulness. There's 100 different psychological strategies to help people with that, but one is just noticing and then gently and kindly taking your attention elsewhere. I'm not really going to have too much time to unpack the CBT, unfortunately, but this diagram here is the CBT formulation. It's the idea that thoughts, feelings, behaviours and body sensations are all intimately connected through our neural networks that sit in our brain. So the way that we feel is intimately and, minutely connected to the thoughts that your brain will generate. And of course, going the other way, that what we do influences how we feel and what we think, and our body sensations are a big part of this. So the pain picture that I see with almost everyone that has, living with chronic pain is this picture. The pain starts as a body sensation. Usually there's an emotional reaction before there's a cognitive reaction or a thinking reaction. But all sorts of negative emotions arise because nobody likes pain. So people feeling sad, angry, helpless, scared, anxious. And then the usual thoughts that come up are things like, here we go again, I hate this, I'm a bad person, what's wrong with me, and how can I get rid of it? And then all sorts of pain behaviours that relate as well, like withdrawing, collapsing, pushing on, stoicism, resting, not resting, social withdrawal. And all of that together creates this pain cycle that can really maintain the pain centrally. And that's probably the most important message to take out of this presentation, is that this is real. I've never met a pain person in my room that is not living with a version of this. And there is a whole lot of really good strategies to help people change and reverse the way they respond internally to pain. So I just guess in summary, and this is probably where I'm going to need to leave it, is working with emotions, acknowledging our emotions, self-soothing, and learning ways to regulate feelings. With thinking, just even noticing those negative pain-related thoughts. Acceptance is massive. There's a lot of data on acceptance and pain, and it really helps us understand how important it is to help us live with pain. Just the idea that trying not to resist something which is effectively a very unpleasant sensation. So there's, again, a whole day workshop in that, but it is an important concept. And just finding new ways to see things or think about the pain, and a whole lot of behavioural strategies as well, like pacings, like boundaries we've talked about, respect for our own rights, knowing our limits, and keeping as active as we're able. So the rest of my slides just really speak to that, talking about regulating emotions. There's different ways to do that. Distraction is one. I usually say to people, distraction is a tool you need in your box, but we need more than that as a tool. Grounding is a fabulous emotional regulation strategy. Breathing, working with thoughts. I'm not going to have time to unpack that too much, but just even just tracking the way your mind goes with the pain is useful. Writing down those thoughts and thinking about whether they're serving you or whether there's another way to see it. Coping and calming self-statements are helpful. So something like, it's tough, but I'm going to get through it. So I'm struggling now, but I'm learning how to cope. And then pain-related behaviours. And just, I suppose, self-compassion and kindness when you try to change things is so important. It's already a difficult situation, and we definitely don't want to make it worse by hammering ourselves, because change is not easy. So I'll stop, and I'm sorry if I've gone over. Thanks, Kat.
You did very well, Jo.
That's psychology on speed right there.
No, that's right. We have a question about someone wants to know more. They could go and research or read about neuroplasticity and how we can train the brain, and also about CBT and emotions.
Yeah, I mean, there's a lot in that. So I can put up some little videos. There's some really useful little YouTube videos about neuroplasticity. There's a lovely book by Norman Doidge called The Brain That Changes Itself, and another one that he wrote called The Brain That Heals Itself. They're great resources for neuroplasticity, definitely. And in terms of pain, I mean, Lorimer and David's work, what's it called? I have to go blank. Anyway, that is whatever.
Explain pain.
Thank you. Explain pain. That's a useful book. The Protectometer is a really useful book that talks about the idea of DIMS and SIMS, danger in me and safety in me. It's a really helpful concept. So the Protectometer and Explain Pain, if you just Google NOI, Neuro Orthopedic Institute, they're in South Australia. They're great resources. And there's another resource from Mike Nicholas. He's a psychologist from the Royal North Shore. He spent 30, 40 years working in pain. He's published a book called Manage Your Pain. It's probably in most public libraries. It's a very CBT focused, but it's got tons of strategies. So I would start there, and I'll send some links via Kat I'll put them up in the chat for some just quick little snips of neuroplasticity videos on YouTube. There's a lot of hope here, and I guess I just want to pass that on.
Does anyone else have any questions?
Yes. I've got a question, please. What do you reckon is the difference between pain education, or pain neuroscience education, as the Americans like to call it, and CBT for pain?
Well, pain neuroscience is just kind of doing what I did today. It's actually just unpacking. I mean, that's what I do first with everyone. I think it's crucial. If people don't understand pain neuroscience, then you've got nowhere to go. You need to get what's going on in your brain. So that's pain education. That's pain neuroscience. The CBT is therapy. It's work. It's sitting often with a therapist, or even just there's lots of online applications, good apps for CBT. But just even beginning to understand that, if I put it back on the screen, this process within yourself, and CBT is really not the only. We've got other tools in psychology that can help with pain as well, but CBT is a really good place to start. So just beginning to recognize, well, what are my emotional responses, and how can I help myself with those? How do I think about my pain? There's a huge amount of work that can be done there. You know, that's probably, you know, just that in itself can take people a long way.
Does anyone else have any questions? Thank you, Jo.
Pleasure.
Our final speaker is Rochelle Hamilton. Rochelle is a clinical sexologist who offers sex counselling to all who feel they may require assistance to understand and accept themselves as sexual beings and meet their sexual goals. Rochelle maintains a broad perspective within this area by being aware of and taking into consideration important variables that influence one's sexual being. These include one's biological, psychological, sociological, cultural, and historical influences. Rochelle practices with evidence-based treatments and comes from a non-judgmental framework.
Kat, I'm going to see if I can get my screen up this time. Otherwise, it lands back to you. Okay, you're ready. All right. Oh, God, maybe I'm not going to. I thought I had all this done too. We've had dreadful time today with this, haven't we, all of us, really? I'm going to get you to do it instead of wasting time. Because, yeah, people would like to finish. I'm sure they've been sitting here long enough when we're talking about walking.
Can you see what I'm sharing there? Can you see it on the screen?
Yeah, and brilliant. Okay, so you can move to that first slide. Thanks again, everybody, for hanging around and listening to all the presenters today. And I've certainly made lots of notes myself from each and every one of the speakers. And again, like everybody else, thanks, Kat, for this opportunity to be able to be part of today. Now, while I've got this little uterus here with lots of little blobs of endometrium around it, it's a roller coaster ride. Each and every one of us who've ever had anything to do with suffering from endometriosis on any level, it is a roller coaster journey. However, and Kat, if you want to hit that little button again for me, she's run away.
Apologies.
Can you hit that for me?
Yes.
Thank you. Making sex about penetration will only limit your ability to have any pleasure. So what I'm talking about today mainly is about the intimacy, reframing intimacy, so as we can enjoy sexual intimacy. Sex is not just about penetration, and sex comes in all shapes, forms, or whatever interpretations by each individual what sex means. You ask a teenager what sex is, you ask a person in their 30s or 40s, and you ask someone who's ancient like myself, They all mean something different to each of us. So if we're focusing our whole entire idea about what sex is, it's going to be unreliable and often not an enjoyable journey. And eventually the act of sex and the thought of sex will decrease your overall desire to participate. Okay, can you flip that button? Beautiful. And you can do the next one as well, flip it. Yeah. So we've got to know what we have. And we've got to understand, and each presenter today has already said, we're more than just a part. We're more than just the endometriosis. We're more than just a uterus. We've got to be in charge to be able to move forward with anything. Want to hit it again? And so that, just keep hitting it for the moment. That means to manage the discomfort and pain. We're learning to feel confident as sexual beings. Oops, go back. Thanks. This is difficult. Sorry, everyone. We've got to be able to feel safe in sexual situations. We've got to be able to improve our communication, which in turn will hopefully make an improvement into the journey of intimate relationships. Okay, thanks. As it's been pointed out by everyone so far, it is a combination of a whole lot of things that is put together that we as individuals will then feel variables of pain, because not everybody, as Marilla pointed out too, not everybody will feel pain with endometriosis. Some will feel the pain in an acute manner, like a stabbing. Some will feel it deep in the abdominal region, and some will feel it throughout their cycle at a different mild to severe component. Okay, Kat. And so with that, and again, what it is an individual experience and this complex interplay of all these pieces that everybody has been talking about today. Okay. So we've got to remember we're not just a part, we're a whole. And I think that's everybody here today wants to help and inform everybody who are patients or friends or relatives or family members, etc., who have had that journey of endometriosis that we've ended up in a doctor's surgery. And I, for one, has suffered that journey on variables throughout my life. And I know what it's like to just feel as though you're a piece of the picture. You're just a box, and then you get shafted from one person to the other. And as each of us have said, and we absolutely admire Marilla's opportunities of the persistent pelvic pain clinic as well, and the different therapies that are offered by everybody. And of course, I've put myself at the top of that list, a sex therapist, sexologist, but we're all there with the same meaning. And I do focus a lot on relaxation and touching, and a body mapping tool that I actually made, a sensei focus, and couple counselling. Can you pop that again for me?
Yep.
Thanks. So what is sex? Sex is different to each and every one of the people in these pictures. We all represent someone. If you hit it once more, a little old lady turns up. Exactly. I'm seeing women who are well into their 70s even with all of this. So we're all different. Oh, where are you going? There we go. We've got to reacquaint sex with pleasure and enjoyment. And like I said right from the beginning, it is more than just the act of penetration. So when I'm talking to people about reacquainting sex with pleasure, I do very much talk about the opportunity to explore touch and enjoyment from different aspects. And sometimes we do have to reinvent the wheel. We can be with a partner for a very long time, and we get stale, we get into routines, we get into that anticipated, I know what's going to happen if they touch me this way or that way, or if I look at them this way or that way. And sadly, a lot of people have come to me over the years and said, I'm even pulling back from kissing or holding hands because I know that might lead to sex, and I don't want to have sex because it's painful and because I don't enjoy it, but then I feel guilty for my partner and myself if I don't participate in something. So they withdraw from the whole act of intimacy, which is really, really sad. I want to hit that button. So the areas that require revisiting when I'm talking to people about this is I do revisit sexual anatomy, not just the inner workings, but our whole body. We've got to refocus and realign our thoughts about our body image. What has that chronic illness done to our body image? How do we see ourselves when we look in the mirror again? Our attitudes and behaviours as well about that concept of self, that concept of self as a sexual being, as an individual, as a partner, and potential enjoyment of pleasure that we feel as though that a lot of the time has been removed. Communication is vital. Communication is something that a lot of people just stop doing. They stop talking to their partner. They stop talking about sexual opportunities because it becomes a criticism in the conversation rather than a critique of the situation that we could try and improve. So I look at ways to enhance that sexual function and communication when you're exploring and redefining that intimacy from all those levels. Thanks, Kat. As it's just been spoken about, CBT is wonderful. It does help. It does assist in lots of individual exploration and awareness of redefining that pain and redefining the person. It also helps then sharing those intimate opportunities of findings with the partner. Using behavioural exercises, I also, now masturbation, everybody's got a thought about what masturbation is, but it's self-directed masturbation, exploring all the sensories, the sensor focus, the sex education and communication skills training. It is really important to be looking at all your body parts that can help and enhance intimacy again. Yep. Mindfulness, can you click the next picture with it? Okay, so mindfulness I use a lot. So CBT and mindfulness, I have found mindfulness to be really, really positive tool in the areas of dyspareunia, sexual dysfunction, the whole lot, for whatever reason that person's sitting there with me. I can do so much with mindfulness. I would never say that I am brilliant at educating someone about it. And so I work very closely with some clinical psychologists in my private practice, and we work like a triangle. So I get so far with some clients and I think, right, we need to decrease the anxiety that's been built up, the anxiety, depression over the years, really focus on CBT or mindfulness. And I get them to do so many sessions with the clinical psychologist and then come back to me, because I sort of work hard and fast in my area. This is a fantastic tool to take away, especially with the areas of painful sex, dyspareunia, vaginismus, and the whole thought process here. If you want to hit it again for me. So it awakens all of those areas, the mindfulness tool, and really, really helps with it. Laurie Brotto is a really good, is really great researcher in the area of sexual health or sexual dysfunction areas, sexuality issues. I've heard her speak at overseas conferences many times when we're allowed to travel. She's written some great books around mindfulness and sexual pain and using it as a tool. Rosemary Basson is, Rosemary Basson has been sort of in the older generation of the studies of sexual dysfunction and pain and management, and I find them very useful tools that I've discovered over the years. When you're looking at the mindfulness-based therapies in reducing sexual distress overall, and as we're sort of, as the other speakers have said, about decreasing that anxiety, that anticipatory pain, whether it be pain, discomfort, or severe pain, it is your individual journey and your definition of that discomfort. And if we can realign it and we can move it sideways, you're not always going to take it away, but if we just move it somewhere else and manage that journey of realigning discomfort, like reframing it and putting it in perspective of what you want to seek out of your individual intimate relationships, and then we can put it together and work together. I'm going to click that. Seduction is a necessary component of sex in long-staying relationships. And again, it'll mean different things to different people. But you've got to love yourself first. You've got to find all your positive trigger points of pleasure again. You've got to own them, and you've got to be brave enough to explore them. So it's about exploring them for you before you can share it with someone else. You don't have to have penetrative sex. However, most of us do actually enjoy it. So if it's been removed due to pain or illness, we've got to find out what can be complementary to that, if it's totally out of the question again, or if it can be a compromising something. So I do talk a lot about compromising in navigating with the body mapping tool that I do. Okay. Yes, thanks, Kat. And again, so some things that do influence sex in general, our histories. So for men and women, I talk about this for both, for all sexual identities, but we're looking at it from a gynecology point of view with endometriosis. And we don't lose the fact that our histories can make us feel guilty already. And so if our history, if we've had awful UTIs in the past, if we've had awful STIs and subsequent discomfort and long-standing issues with sexual health issues, also with aging, things change whether we like it or not. We can only manage things so far, but with normal aging process and decreased normal vaginal lubrications and vulval health, etc., those things will impact our already vaginismus and dyspareunia with endometriosis pain. So we've got to put the whole story together, and we've got to look at it as a whole component of that change and how it's affecting our sexual intimacy and our exploration of that journey. So medications might alter things for the good, bad, or indifferent. And not just talking about medications from an endometrial management. I'm talking about medications in general, like with blood pressure medications, diabetes medications. All these things are altering our perception of health, of self, and of our body image in general. Thanks, Kat. It's okay. So I'm very direct in my approach to this with my clients. I am very direct in how I ask the questions. There's no good beating around the bush and fluffing over things when you're trying to talk about sex with anybody. So I always say, you know, if someone's been referred to me, I go, who referred you? And then I go, right, did they warn you how direct I'm going to be? Did they warn you that this conversation might be a little bit much for you? So I've got to pace sometimes, but sometimes we can go straight in. So also what's really important is the engagement with the partner. In the ideal world, I will speak to two as a couple. However, sometimes I will definitely ask the separation component because there's some things people just don't want to do anymore, not just because of endometrial discomfort, but also sex. They don't want to participate anymore for whatever reason. That's okay, but that's where the compromise has to happen, because one person will come with the idea, well, Rochelle's going to fix this, we're going to have great sex again. No, we can't always fix that. But what we look for is changing the story about intimacy. And I think that's where the compromise has to be. We also have to look at the options, sexual positions, options that are available, tools that we can engage with, and whether or not you're brave enough to take that leap. Yes, Kat. So, as I keep saying, redefining intimacy, learning to explore self in a different way, using a body mapping tool that I have made, explore sexual positions, explore the opportunity to incorporate sex toys or other equipment. That is not going to be for everybody. But it always makes me surprised in a nice way how people do embrace that option when it's given to them, because someone in that party is pretty enough brave to take that on board. But if I'm the third person suggesting it, it comes out a different way. It doesn't sound so bizarre for some couples. Yep. This is a body mapping tool. And again, I'll make that statement. Making sex about penetration will limit your ability to have pleasure. So on this sort of tool that I make, it's, you know, my cookie cutter cutouts, male and female, 2 females, 2 men, doesn't matter when I use this. But what I do, it's an exploration. It's a little bit of sensor focus and CBT, but I'm using mindfulness with it. So I get people to do this exercise that they've got underwear on. This is not a talking exercise, and this is not eye-to-eye contact exercise. So the person doing exploring of the other person first. So if I was doing this with my partner, they would have their eyes shut the whole time. We would not be talking, and they would have their underwear on still. Genital area is totally out of the question of touching this, because what we're trying to do is explore other sensitive areas of our body and what it makes someone feel. Does it make them feel uncomfortable? Does it make them feel tighter? So what I'm asking that person doing the exploring is to observe the other partner, how they're breathing. Is it shallow? Is it deep? Is there nasal flaring? Do they move when they touch somewhere? Do they sort of pull back and move back into the bed or whatever? So all of those things I'm asking, and they mark the chart with a tick, a cross, or a straight line, whether or not they think they like that and didn't like that, or I wasn't sure. They bring this back and we share it. So I don't want them to talk about this exercise either between them, because again, this is not a criticism of each other. This is about a critique of how then can we enhance all the bits that are ticked okay. Can we build that into the new pathway of sexual touch and how we might do it? Okay, Kate. So the areas are often required consideration and compromise, exploring the intimacy, redefining it, exploring the sexual positions, negotiating sexual contact and frequency. Really, really important. And potentially looking at sex toys. And I'm not always meaning just a dead, boring, horrible vibrator. There's lots of sex toys out there that can be positive in relationships. Yep. These are some. And what's up on the left in that powder, when you see the powder, it is like, you know, popping candy. So you dust this over someone, and we're looking at enhancing ways of pleasure, whether it be licking, kissing, touching, stroking, fingering, whatever. And that dusting, if you lick that, then the body that it's on and then the mouth of the person doing the licking, it's like popping candy. That can be okay for some people. Some people it'll be out of the question, but it's worth a discussion. Different types of vibrators that can be used for both or all sexual identities. Different types of lubricants, some will make that will heat up, and some that will get colder that are out there. You do have to be careful if you've got a history of UTIs or bacterial vaginosis, things like that. It can exacerbate that and cause a discomfort. So I do talk about the history of some of those STIs or issues in people. Yes, thanks, Kat. More sex toys, lots of different sex toys. And change that. Okay, sexual positions, really important. Some positions, now some of these positions I've found that work really well for people, older women in general that have issues with a bit of incontinence, stress incontinence with orgasm. It also helps some of these positions take that fear away, because sadly some of the women have said to me over the years, I don't dare engage and I stop before I experience my orgasm, and I really miss an orgasm, but I feel as though I dribble a bit, and then it makes me embarrassed because then I can smell the urine, even though the partner will say, it's all right. Positions, really important. Positions for pain, really important. You do have to practice. You do have to give things a go, because only you and your partner know whether or not that's going to be successful. in either alleviating that pain associated with sexual penetration and endometriosis, or at least it makes it okay. And then you're compromising with frequency and touch, etc. Yes, Kat? So don't sweep these things under the carpet. You need to explore. If you want to flick that again and again. And you've got to find the lover within you, and you've got to enjoy. But only you can make that step forward. Okay, I think I'm finished. How did we go for time? Thank you. Thanks, Kat.
Does anyone have any questions? There was someone that made a comment. There's been a few comments come in. Someone's made a comment about being quite scared to have sex again after a hysterectomy. Have you got anything that you could say to that, Rochelle?
Yes, and I can put my hand up with that. I've had the hysterectomy a long time ago, and it is scary. It's like scary after endometrial ablation as well, which, you know, you just anticipatory discomfort, anticipatory pain, usually of insertion, and that strange feeling. And, you know, again, it's working yourself up to it. And that's where, you know, something like the body mapping tool, about not just focusing on penetration, but slowly working back to it again. And positions, you will find positions will help about that as well. So don't be afraid, just pace it.
Thanks, Rochelle. I don't think we've got any other questions.
Yep.
If anybody thinks of any questions that they'd like me to forward through to Rochelle, just send an email to Catherine at Endo Help, and I can ask on your behalf and we'll get them answered for you. Someone said, can I please get some more info about the pelvic pain program online that Joe and Celia are doing?
Have you got a link, Celia, you can put up for that?
Yeah, there is one actually in the chat already, but I'll do it again. It's 6 weeks online in an evening, starting soon, isn't it? So.
That's right, yeah, and it's cameras off, and it is like, if you want to interact, you can, but you certainly don't have to. We've run one before, and it was you know, people could be quite anonymous.
Fantastic. Well, we have gone over time by quite a bit. I think people are getting a bit tired, but thank you. Oh no, sorry, I think I do have a question. Sorry, that's coming. What's the best way to talk to your partner about sex rather than just saying, I'm sick of wham bam, thank you, man?
Fair enough. And again, it's doing it in a neutral area, not when you're both in bed and there's this anticipatory opportunity for one and not both. So you've got to pick your moment, obviously, which is a bit hard sometimes, but being honest about what you feel, being honest about the touch and about the thought, and that you do want to participate, hopefully you do, in sexual intimacy and touch. But that reframing is really important, and that's what I focus a lot on. Yeah.
There's been a follow-up question, which is, do you do online sessions?
Yes, I do. I do Zoom appointments as well. Yeah.
Fantastic. Rochelle, if you could forward me the link to where people can find you online or how they can make an appointment, and I'll forward that through.
Okay, thanks.
Thanks to all our speakers and to everybody. It's been fantastic to hear everybody talk, and there's been some great questions. So thank you so much to you all. The recording will be up sometime later this week on the Endo Help website, and someone has asked for all the links, so I will try and make sure that I get them all, and I'll make sure they go in a follow-up email to you all. Thanks so much for all your time, and thanks to everybody who's walking.
Thank you.
Thanks, everyone.
Thanks,
Thanks,
everyone.
Thanks.
Thanks, everyone.
Thank
See
you.
you.